Okay, we have stopped. We have last time. Hello, class. Anyways, welcome back. I think last time we stopped at aortic, not aneurysm. We stopped at atriovenous fistula, right? So, how do you treat atriovenous fistula? Is you just can do a simple embolization or an excision of the fistula and recorrection with the Dacron patch. That's what we expect, and that is more than enough. And more important question there was Nicolendi Brinham sign, and I told you how it is proximal occlusion of the AV fistula tract will make the limb normal, that is pulseless. The limb's pulse will become normal, venous pressure becomes normal, blood pressure becomes normal. So that is what is about atriovenous fistula. Last time what I missed is, that's the reason I wrote all the topics that I need to cover today and come here. Last time what we missed was arterial ulcer. The most notorious forms of ulcers that we face is malignant ulcers followed by arterial ulcers. Because arterial ulcers are formed as there is arterial occlusion. So the body does not have enough arterial supply, that region. So that arterial supply lack is causing ulceration, because it is making the region dry. It is making the regions all immune system protections weak because of less arterial supply. So arterial ulcer is always a notorious ulcer. How well you can treat, we don't know. How well we can treat, we don't know. Why? Because it is an arterial ulcer. Are we able to improve the blood supply if it is an occluded artery? And for improving a arterial supply, the biggest problem is you have to do a bypass graft. Usually you cannot just put a stent is only for a small occlusion. It's only for a small occlusion. If that is a small occlusion, we can put a stent and come off. But it's at length atherosclerosis, we can't be putting a whole lot of stents. So what we have to do is we have to do a bypass graft. It is not possible in the case of Burgess disease. In the case of atherosclerosis, yes, it is possible. So the treatment of arterial ulcer ultimately depends on the amount of blood supply that we are able to restore to that particular region. That is how we can actually plan. It's because of the dry skin, it's because of loss of immune mechanisms, and also it's because of lack of blood supply. If the arterial blood supply is good, the wound healing is better. That's the reason you see anemia causes poor healing capacity, poor wound healing. So we need good arterial supply for an ulcer to heal. In a case of arterial ulcer, because of the defense mechanism lost, because of the loss of skin integrity, because of dryness, and because lack of good oxygen as well as nutrition, the wound does not heal at all. So making an arterial ulcer heal is quite a bit of a task for us. So it is better to prevent an arterial ulcer than to treat an arterial ulcer. So if the patient comes to you in an early state, you probably tell him you have to take these measures to protect yourself from this arterial ulcer. Or you can tell him that this ulcer will only heal if you take proper care. So once you get an arterial ulcer, the ulcer edges are punched out. They're horrible ulcers. They're dry. They're discharging horribly. Mostly because there's no blood supply, and it is a very good culture medium for anaerobic bacteria to grow there. So we should be more careful in preventing the infection also. So it is badly discharging, dirty wound, punched out edges, it carries infection, and of course poor healing capacity. So how do you work this case up? You should work this case up normally by doing a color Doppler of the lower limb to check the patency of the arterial blood vessels, number one. Number two, on examination you have very rough, very punched out edges, the the floor is covered by slough, the base sometimes can be the underlying muscle, all the subcutaneous tissue gone, and it is dirty, foul smelling, and then there are no pulses. You cannot feel the pulses, or the pulses are feeble because of lack of blood supply. Then you will do a color Doppler, you will do culture sensitivity, followed by a very judicious, you should be doing a judicious debridement till you see clear red blood coming. That is when the ulcer will heal. Otherwise, the ulcer will never heal. And ultimately, most of the arterial ulcers will end up in a gangrenous state, followed by either amputation of that particular toe or whatever, or we may have to do a below knee amputation or an above knee amputation depending on the level of obstruction of the arteries. Okay, that is arterial ulcer. Then we'll move to the most important topics, that is thoracic outlet obstruction. This is very important because it will come attacking you even in your post graduation. It is important for you in the undergraduation level as well as important for you in the post graduation level, and in the entrance point of view also it is important. Simple, the word itself says what it is: thoracic outlet obstruction. So what is thoracic outlet obstruction? The word is thoracic outlet obstruction. So which is the artery that is going to be involved? It is simple. It is the subclavian artery that will get involved. Most of the times it is the subclavian artery. So what are the things that are going to be having a problem? Your upper limbs. Your upper limbs are going to suffer because of thoracic outlet obstruction. Usually it is right greater than left, or some books say it is equal on both the sides. So what are the causes for thoracic outlet obstruction? The causes for thoracic outlet obstruction are: number one, it is a cervical rib. Long growth of the transverse process of the 7th cervical vertebra. Anomalous insertion of scalenus medius muscle. Scalenus medius muscle, please remember, anomalous means it is not getting inserted into the place it is. Sometimes it's a fibrous band that is causing the obstruction. And number 4 is tumors, either mediastinal tumors or the tumors of the lung. And that particular lung tumors that causes this particular system involvement is apical lobe, and that is called as apical lobe, tumors of the apical lobe. So you should be very careful when you should be knowing about what is this. Okay, it is, and most of the times it is the neurogenic obstruction that is causing more symptoms than the arterial. Arterial obstruction is more damaging, but it is the neural symptoms that you're going to get. Okay, there are about 4 important tests that you do in a case of thoracic outlet obstruction that I'll be telling in the course of time. So how will the patient, or how would the patient come to you? The patient will come to you with numbness, pain and paresthesia of the upper limbs. Pain and paresthesia of upper limbs. Sometimes the patient will also complain of discoloration of the upper limbs. Cyanosis, that is basically cyanosis of the upper limbs. Then when he does some maneuvers, the pulse is written and he becomes better. And if it is unchecked, most probably it will go into gangrene and we may have to do an amputation. So basically you have to prevent. It is more easier to prevent than to do any damage. And because of thoracic outlet obstruction, you get something called as Horner's syndrome. Horner's syndrome is nothing but ptosis, athetosis, chorea, anhydrosis of the face, one side of the face, with involvement of the sympathetic ganglion of the cervical vertebra because of this thing. So when a patient comes to you, you should see for Horner's syndrome, you should see for the pulses of both radial, brachial and axillary. Then you should check for what is the problem that the patient is saying. If he has pain, if he has got paresthesia, you have to see them, and then you have to first examine, followed by you have to investigate. How are you going to investigate? Sorry, how are you going to test him? There are 4 tests that you have to remember at any cost. At any cost, you will have to remember these 4 tests. You don't have to remember the mechanism of action, even I am not going to tell, but you have to remember the 4 names. Number one is Adson's test. Adson's test previously was asked because Adson's test was previously asked, how do you elicit Adson's test? Adson's test is nothing but you will ask the patient to take a deep breath and then bend, or you ask the patient to hyperabduct the chin opposite to the side of the lesion and then check for the pulses. Most of the times it's the absence of the radial pulse that you will feel, and that is Adson's test. Adson's test, Roux test, costoclavicular test and costoclavicular test, as well as hyperabduction test, also called as hyperabduction test. Then there is one test called as Allen's test. How do you do Allen's test? You have to ask the patient, first block both the elevate, do exercise, block both the radial and ulnar arteries, then ask the patient to exercise. Okay, if it becomes pale, if it's changing its color, which means there is a blockage. Fine, there is a blockage. And then you have to remove one. If the blanching appears, if the blanching takes place, it is that artery is not blocked. And then again block this and open the other. And if the blanching does not occur, which means that is blocked. That is Allen's test. That is Allen's test. So when you do these tests, you will know the patency of that particular vessels. If Allen's test is used for radial and ulnar arteries, and most common symptom in thoracic outlet obstruction is going to be the ulnar artery, as well as the ulnar nerve that is going to get involved. So the patient will have hypothenar muscles wasting, tingling and numbness of the fifth and the half of the fourth finger, half, followed by, along the course of ulnar nerve, the patient will have tingling, patient will have paresthesia, or he will not have decreased sensation. He'll have decreased sensation of pin rolling movements in that particular region. So you will do this, and followed by, then you will start investigating for the reason for thoracic outlet obstruction. The number one test that you will do is a chest X-ray. Okay, a chest X-ray is the most important test that you're going to perform. Then why? Because in the chest X-ray you will know if this, including the cervical region, you will know if there is a cervical rib, number one, if there is a fibrous band, if there is a tumor in the apical lobe of the lung or any mediastinal tumor. Then you will perform an angiogram, either a CT angio or an MR angio. Otherwise, you will do a normal percutaneous angiogram to know exactly where is the problem. CT chest, MRI of the neck. MRI of the neck because of the soft tissues. CT chest is more important. So you will do these investigations, then you will come to a definitive conclusion. If it is a tumor that is causing this, you will have to treat the tumor proper. If it is because of this scalenus medius muscle, you will have to simply divide the scalenus medius muscle and the problem is solved. If it is a cervical rib, you have to excise the cervical rib. If it is a long transverse process of the 7th cervical vertebra, you will have to excise the long cervical process. That's it. That is what is the treatment. Thoracic outlet obstruction. Then, I already told you about Horner syndrome. And what is the complications? If it is neoplastic lesions of the lung, most likely the prognosis is poor. The problem with the other surgeries is, it is because the side has got so many important structures, you may damage any of them. It could be a brachial plexus damage, it could be a arterial damage, or it could be a venal damage. And all this leading to edema, and the patient can develop upper limb edema. Venous edema or lymphatic edema, anything is possible. Because you're dividing a very crucial structure. Sometimes you can develop a lymphogenic fistula, lymphocutaneous fistula. If by mistake you're going to injure the thoracic duct, which carries the lymph from the cysternal of the abdomen. So you should be prepared for all these things. Then we'll talk about Raynaud's phenomenon and Raynaud's disease. What is Raynaud's phenomenon? Raynaud's phenomenon is that particular autoimmune condition, which could be idiopathic, which could be a secondary due to some disease, or which could be a Raynaud's disease proper. So when the patient comes to you with Raynaud's disease, what you have to do is you have to understand what exactly happens in Raynaud's phenomenon. Raynaud's phenomenon is one of the three cycle or a three circle of Burgess disease. Here Raynaud's phenomenon is a separate entity too. So what happens in Raynaud's phenomenon? Whenever the patient is in a stress, whenever the patient is a patient who suffers from migraine, a patient who is living in cold countries, these patients, especially females at the age of 40, these are the people who suffer from Raynaud's disease. So what happens? Initially there is a phase of blanching. Okay, initially there is a phase of blanching where the artery gets compressed because of the cold weather or the migraines trigger. It gets compressed. Then the stage of cyanosis. As the artery is blocked, the region becomes cyanosed because of lot of deoxygenated blood getting stranded there, or lack of oxygenated blood will cause cyanosis of this region. And then stage of rubor. Stage of rubor is once if the patient goes into a warm region, or when she does some maneuver or exercise, automatically that thing is going and the patient's limb becomes red. This is stage of rubor. So the first stage in this is blanching stage, then a stage of cyanosis, and finally stage of rubor. These are the three important things that you will see in Raynaud's phenomenon. Raynaud's phenomenon. Who are the people who are going to suffer most likely? Most likely the people who are suffering from this particular disease or phenomenon are females 40, stress induced, migraine, as well as autoimmune condition. So these are the things then you do. When it is autoimmune condition origin, it is called as Raynaud's disease. So how are you going to treat this patient? If it is simple Raynaud's phenomenon, most of the times the patient goes into a warmer climate from a colder climate, or treat the migraine, the patient settles down. But if it's Raynaud's disease, you have to start the patient on a long-term high-dose corticosteroids. Unfortunately, there is no permanent cure for this particular Raynaud's disease. You have to give the patient calcium channel blocker to keep the vessels vasodilated, that is nifedipine, and you have to give corticosteroids to prevent the attacks as well as the autoimmune process. So Raynaud's phenomenon is an entity that the patient has to live for life. There is no clear-cut cure for the Raynaud's phenomenon or Raynaud's disease. Keep the patient in warm, do some maneuvers, then you have to give calcium channel blockers, you have to give corticosteroids if it's proven. And Raynaud's disease should not be the conclusive diagnosis unless and until the secondary causes of Raynaud phenomenon, that includes Burgess, that includes cold climate, that includes that the patient is having migraine. All these have to be proven, otherwise then only you can put a conclusive diagnosis of Raynaud's disease, because Raynaud's disease is an autoimmune condition and it has to be proven. How do you do? You have to do stress induction tests. You have to do CBP with ESR. You may have to do some specific tests for this Raynaud's phenomenon, and then you come to a conclusion. There is not much of surgical treatment here, but it is more medical treatment, and if gangrene sets in, then you have to do a amputation. I think I forgot to tell you about arterial disease. I told you, I think the patient will end up in amputation. Otherwise the patient will need a full precise debridement, right? Yeah. Then after which Raynaud's phenomenon, diabetic foot. So what is diabetic foot? Why are we worried about diabetic foot? Diabetic foot is basically the problem with three important things. One is the neuropathy. Number two is the patient is having a decreased immune status because of diabetes. He's got poor blood supply because of microangiopathy, as well as the patient has neuropathy. And the neuropathy is basically of three types: autonomic neuropathy, sensory neuropathy, and motor neuropathy. When sensory and motor neuropathy are together there, the joints of the lower limb, the arches become flat. And this particular flat foot is also called as club foot. What is it called as? It is called as club foot. The muscle, the tendons that are holding the joint together are simply dispersed because of the motor neuropathy and sensory neuropathy making the soles flat. This is called as club foot, and this club foot will lead to flattening of the soles because there is no arch, flattening of the soles, and the patient with peripheral sensory neuropathy, even if he walks on a thorn, he walks on a hard surface, if he walks on a fired surface, if he walks on a glassed surface, whatever he will not have any sensation, and all the muscles and the tendons are so near, so it will get immediately infected. This is called as club foot, or also called as rock bottom foot. Please remember rock bottom foot. So it becomes rock bottom foot, and this rock bottom foot will cause ulcers that wouldn't heal, and these ulcers of all these three specific origin, because of loss of immunity, loss of blood supply, loss of nerve supply, will form something called as a diabetic foot. And diabetic foot is a typical case of tropical ulcer. Tropical ulcer. And the problem with diabetic foot is it is again a vicious circle. You have to control the sugars in order to heal the diabetic foot, and the diabetic foot will not, and the sugars won't come down till the diabetic foot is resolved. So this is a big issue not for us, more to the anesthetists, because they cannot be giving anesthesia to somebody whose sugars are 300, 350 or 280, 300. So we want the sugars to control in a diabetic foot, but unfortunately we are not able to control the sugars because of the stress the diabetic foot has caused. So it's a vicious circle. It is going to trouble us. So what do you do in this? You have to initially debride. You have to send it for culture sensitivity, do the investigations, etc., etc. What is happening to the patient? You understand what are the things that you will do. And then once you finish off, as in the case of ulcers, you will go and give the patient a chance. To save the foot. So you will do all the dressings, you'll have to ask the patient to keep his sugars under control. You have to ask him to wear slippers and walk even in the house. He has to protect himself from all the things, take vitamin B complex, that is B12, to prevent further neuropathy. So all these things are there, but ultimately diabetic foot, if it does not improve, will end up in amputation, either a below knee amputation or an above knee amputation, depending at the site of problem. Most of the times it is below knee because we don't get to see such high problems. But yes, if atherosclerotic pattern is set in a case of diabetic foot, we can't do anything, and we probably end up doing a above knee amputation. All right. Then aortic dissection. There is a very, very, very famous entrance bit where people or the students get so much confused. I myself got confused, but at the end of the day I learned it and I put it correct. The question goes like this: 50-year diabetic male presents to you otherwise normal, a 50-year diabetic male otherwise normal, 60-year diabetic male presents to you in the emergency department with severe retrosternal chest pain, and then the patient will have either hypotension or hypertension. He'll have either hypotension or hypertension, and it happens all of a sudden. It happens all of a sudden. So when you see, you will put myocardial infarction. But the answer is, it's not myocardial infarction, it is aortic dissection. It is aortic dissection. Severe shooting type of retrosternal pain with hypo or hypertension. Hypo or hypertension with peripheral pulses diminishing because of aortic dissection. It happens because of aortic dissection. It happens because of aortic dissection. Aortic dissection is an emergency. You have no other option. Do a cardiac, do a 2D echo. You will understand that there is a dissection. You may immediately take the patient for corrective surgery. It's corrective surgery, but it is basically an emergency. It is basically a emergency. You have to understand this aortic dissection. Aortic dissection. It's so hot here. Yeah. After aortic dissection, we will come to something called as a very, very, very important topic, especially in the entrance point of view, as well as theory. It's a 4-mark question. In the theory, it's an important entrance bit question that is called as abdominal aortic aneurysm. Triple A. Aortic aneurysm. Abdominal aortic aneurysm. Abdominal aortic aneurysm can be of 2 types. Okay, abdominal aortic aneurysm can be of 2 types. One moment. Oh, sorry. In the aortic dissection, I missed something. That is called in aortic dissection. I missed something. Which is the most common site of involvement of abdominal aortic dissection? It is right lateral wall. Right lateral wall. More commonly involved is right lateral wall of the aorta or of the aorta. It's basically circumferential tear. It's basically circumferential tear. It is classified as 2 types. It is classified in 2 different methods. One is DeBakey's classification and one is Stanford's classification. In DeBakey's classification, it is type 1, type 2 and type 3. In Stanford classification, it is type A and type B. In DeBakey's classification, type 1 is a descending aorta along with ascending aorta involvement is DeBakey's type 1. If it is only ascending aorta, it is type 2. If it's only descending aorta and below, descending aorta going below, it is type 3. Whereas in Stanford classification, type A is if involvement of both the ascending and descending aorta, okay, is that thing, and if it's only involving the descending aorta, it becomes type B. And most of the times it is the descending aorta that is getting dissected. It's getting dissected. You have to remember DeBakey's classification and Stanford classification. DeBakey's is 1, 2, 3 and Stanford is A, B. All these are entrance bits. Then we'll go to abdominal aortic aneurysm. Abdominal aortic aneurysm is a dilatation, abnormal dilatation of the aorta greater than 50% of its circumference. It's always greater than 50% of its circumference. That is when you called as abdominal aortic aneurysm. That is when you call as abdominal aortic aneurysm. Okay. So in abdominal aortic aneurysm, what happens? Why are we worried? Why are we worried in abdominal aortic aneurysm? Because it comes to people with in the age group of 6th and 7th decade. Because it comes to people with in the age group of 6th and 7th decade. And actually forgot to tell you, I want you guys to ask questions. You have to ask questions so that we can, at the end of the class, I'll try to solve them. Ask questions so that, okay. So you have to ask questions and based on which we will decide. Based on that, I'll tell you what exactly is needed. Is that fine? Okay. So in abdominal aortic aneurysm, it could be descending aorta, it could be ascending aorta, but more likely it is going to be the descending aorta. And you should remember, in descending aorta, the most common site of problem with descending aorta is left flank or left retroperitoneal space when it gets ruptured. Basically, aneurysm, first you should know what is an aneurysm. Aneurysm is abnormal dilatation of the artery greater than 50%. Okay, it's mostly greater than 50%. True aneurysm, false aneurysm. True aneurysm, all the three layers, that is intima, media and externa, all the adventitia, all the three are involved. With only some involvement, it is called as false aneurysm. Okay, true aneurysm, false aneurysm. And then there is another classification that is classified as number 1, number 2, number 3, number 4, number 5. Number 1 is fusiform aneurysm, which is actually a true aneurysm. Saccular aneurysm is only about either one part of it is dilated or two part of it are dilated. Number 3 is mycotic aneurysm. Mycotic aneurysm is basically a misnomer. Mycotic is, you think it's fungus. No, it is because of a bacterial infection or fungal infection, but more likely it is bacterial. Staphylococcus greater than Salmonella typhi. Then you have pseudoaneurysm. And then you have saccular cricoid aneurysm. These are the 5 different aneurysms that you will have to remember. Amongst this, I already started abdominal aorta. That this is basically a true aneurysm fully. All the 3 layers are here involved. So it's basically a 3 most common symptomatic aneurysm is your circle of Willis aneurysm. What is that aneurysm called as? Berry aneurysm. Then followed by the most common aneurysm is the aortic aneurysm, followed by the iliac aneurysm. Followed by the iliac aneurysm, then popliteal, followed by femoral. Popliteal and femoral are causes for aneurysmal ruptures in 90% of the cases of the peripheral parts. Okay, peripheral parts, it's 90% of them because of aneurysms caused in the popliteal as well as the femoral artery. Aortic aneurysm is the most common, followed by the iliac. Most dangerous aneurysm is the iliac aneurysm because the fatality rate is about 40%. Most of the times abdominal aorta is symptomatic, so we will take care of them, and then followed by we will do the proper required surgery in a case of abdominal aorta. Why is abdominal aorta? That is a full length dilatation greater than 5.5 centimeters. There is greater than 5.5 centimeters. Whenever you see a greater than 6 centimeters dilatation of the abdominal aorta, there is no question but you operate. That's basically an entrance bit. That's basically an entrance bit. So what is happening in abdominal aorta? When it is growing at greater than 1 centimeter per year, symptomatic abdominal aorta, the patient is able to see the pulsations and sometimes feel the pain in the loins. You have to think that this patient is symptomatic abdominal aorta aneurysm. And what are the causes for these aneurysms to form? Number 1 is basically a degenerative change. Number 2 is atherosclerosis, 60-70, the 60s and 70s decade. Number 2 is atherosclerosis. Number 3 is giant cell arteritis. Number 4 is Takayasu arteritis. Autoimmune conditions as well as degenerative processes. Okay, autoimmune conditions as well as degenerative processes. These are the reasons why the patient is. And abdominal aortic aneurysm is having a strong predilection for men and those who smoke. Females are less affected, men are more affected. Okay, men are more affected, and it is one of the leading causes of death in healthy men in the US. Abdominal aortic aneurysm. So the patient, if is symptomatic, what are the reasons why we operate? If the patient is symptomatic, number 1, it is greater than 6 centimeters in diameter. Remember, in popliteal and femoral, anyhow I'll go there and we'll talk about it. In abdominal aorta, it is greater than 6 centimeters dilatation. Okay, symptomatic. Patient is having hematuria. Hematuria also is a symptom, so symptomatic hematuria. If the patient, if it is growing greater than 1 centimeter, and this because of the cause of an infection, if it's a mycotic ulcer, the chances of rupture are very high. So you have to operate this particular patient. You have to operate this particular patient. Investigation of choice actually is CT angio in a patient who has good renal uh, parameters, GFR. If his GFR is greater than 80 or 75, you probably will do a CT angio, investigation of choice. Otherwise, in patients with renal disease or renal insufficiency, the investigation of choice becomes MR angiogram. MR angiogram. You will investigate, followed by you have to do surgery. Once you investigate, once you see the pulses, when you can see the pulses, you will watch. There is a strong telling that tetracyclines, okay, tetracyclines and aspirin, etc., will help in healing. But how, it is not proven. So I'm not talking about it. Some books say so. I'm trying to give you an information, but I'm not happy about it. It is better once it becomes symptomatic and all the criteria I said, we will go for a surgery, abdominal aorta surgery. Some people, there are two approaches. One is peritoneal approach, one is a transperitoneal approach. Multiple times if the surgery is done, we'll go for a transperitoneal approach, and transperitoneal approach is important. Once you do the surgery, and please remember, whenever you're doing abdominal aortic dissection surgery, before which the more common presentation is the patient has basically carotid stenosis. If you don't check for this carotid stenosis, if need be, perform a carotid endarterectomy, you may ultimately end up the patient in a cerebrovascular attack. So first, the patient in 6th to 7th decades, most of the times, please remember, most of the times will need a carotid endarterectomy. Okay, will need a carotid endarterectomy for a performance of surgery or in the abdominal aortic aneurysm. Most common complication of about whatever in a symptomatic fatality rate is about 30%. In a ruptured abdominal aortic, in a selective case also it is high, 15%, but unfortunately you have no other option but to perform. So what will happen here? What is the most common symptom that the patient will present post-operatively is diarrhea. Diarrhea, and because we are performing on the abdominal aorta, the chances are either inferior mesenteric artery more likely or the superior mesenteric artery getting involved and that particular region going into edema and gangrene. Edema and gangrene. The patient will die of peritonitis rather than this thing. If diarrhea is persistent after 48 hours of the correction of abdominal aortic aneurysm, more likely we have damaged either superior mesenteric artery or the inferior mesenteric artery. So once you do this, you have to be careful in observing. The next artery that is going to get damaged is iliac aneurysm. That most commonly involved is common iliac, about 70% of the cases. 15% of the cases it is the right common iliac. Together they form such big number, 95 plus, so hardly anything left for left iliac artery. So most common artery and most dangerous artery aortic aneurysm is iliac artery aneurysm when it gets ruptured. Fatality rate is almost 40%. Aortic followed by iliac, followed by popliteal, followed by femoral. This is the order that it goes. Only peripherally involved. When it is only peripheral you are talking about, it is popliteal followed by femoral. When you are asking about central, it is aorta followed by iliac. And number 2 is the most common symptom presenting aneurysm is the circle of Willis or the Berry aneurysm. You have to remember all these are entrance questions. So many entrance questions in the last. So what is the age group does it come, and as I said, what are the criteria for going for an abdominal aorta dissection, abdominal aorta aneurysm. All these are entrance questions. So carotid endarterectomy, that is an entrance question. All these are entrance questions. So you have to remember each point. So your preparation should be how you're going to balance yourself between theory exam as well as practical exam. Most common side effect is diarrhea. What is the arteries involved? Superior mesenteric artery, that is this thing. extraperitoneal approach, peritoneal approach. These are again, these two are important questions. Hematuria is important question. So all these are important, and whenever an iliac artery is iliac artery aneurysm gets ruptured, the presenting symptom will be hematuria. Presenting symptom will be hematuria, which with severe flank pain, and patient comes to you almost in case of shock. So it becomes an emergency. It becomes a emergency surgery. And for iliac thoracic, aortic, descending aorta greater than 6 centimeters. For ascending aorta or aorta, it is 5.5 centimeters. Greater than 5.5 centimeter, if aneurysm is present, you have to operate. If it is 4.5 centimeter, you have to operate iliac artery. Okay, you have to operate iliac artery. And then if it is 2 centimeters and more the diameter, you have to operate for both popliteal as well as femoral artery. Femoral artery is only 2 centimeters, please remember, because if it gets ruptured, torrential bleed, and you will lose the patient in no time. And the vessel is so superficial, any small simple hurt can cause this thing. And all the aortic aneurysms, the bleeding is in the retroperitoneum. It's not into the abdomen, it's in the retroperitoneum, because the major vessels are all retroperitoneal structures, not peritoneal structures, please remember. Then you will come down to femoral and the popliteal artery aneurysms. Popliteal artery and femoral artery aneurysms, both of them are very dangerous, notorious aneurysms. They're very dangerous, notorious aneurysms. Even if they are 2 centimeters, you have to operate. You have to operate if they are 2 centimeters. No question of leaving them. And most of the times, these are mycotic infected aneurysms. So even more careful. Or when you would have done a bypass, in the bypass, this particular aneurysms have developed. So these, when they are 2 centimeters, this 2 centimeters for popliteal and femoral is an entrance question. So 2 centimeters, 5.5 centimeters, 4.5 centimeters, greater than 6.5 centimeters, each of which is important. These days that we are doing what you call as endovascular, ultrasound or a CT guided endovascular correction of aneurysm or aneurysmal clipping. This is called as aneurysmal clipping, endovascular aneurysmal clippings. This is what we are recently doing now. So this is also important. Endovascular aneurysmal clipping also is important. We are not opening up and then doing the surgery. Okay, and how do you, after which, what is there? Okay, very important question. Subclavian artery stenosis. Do you know what is subclavian artery stenosis? Subclavian artery stenosis is important. Please remember, what is the anastomosis around the scapula? Very commonly asked entrance question. The first part of the subclavian artery and the third part of axillary artery take part in formation of anastomosis around the scapula. Why I'm telling you, I'll come back. Then you have at the first part of subclavian artery, there is a stenosis. More likely this stenosis is because of a mechanical or a traumatic, mechanical, traumatic or atherosclerotic. This stenosis will cause upper limb, both upper limbs having problem. If it is left-sided, which is more common, right-sided is more common. Left-sided is also common, but not as much as the right. So when you have this abdominal subclavian stenosis, what is happening? Your upper limbs are going numb. They're having pain, paresthesia. Again, they're having cyanosis. Again, when they do maneuvers, etc., it will improve. But the stenosis is still present. You have to treat the stenosis. How do you treat? You probably do a peripheral angiogram, place a stent. But this is what you do. How do you do? Peripheral angiogram is the investigation of choice. But this is not what is usually asked. There is something called as subclavian steal syndrome. So subclavian artery is part of your vertebral artery. Vertebral artery. It supplies blood. It continues as vertebral artery. So what does vertebral artery do? It becomes basilar artery. to the brain. So when subclavian stenosis is there, subclavian artery stenosis is there with a collaterals around the scapula, okay, anastomosis around the scapula. When you're doing exercise with these both the limbs, this particular region will need more blood. So what is happening? This subclavian artery, which is part of the vertebral artery, is pulling the blood or bypassing the blood to the upper limb region. Okay, it is stealing the blood from the brain, so the patient will have an immediate syncopal attack. This is called as subclavian steal syndrome. So what is happening? Because of the stenosis of the subclavian artery, when the demand is high for subclavian artery in the upper limbs, the blood supply through the vertebral artery is diverted to the upper limb, which will cause a sudden collapse or sudden decrease in the blood supply to the brain, and the patient will have a syncopal or a blackout attack. This is called as subclavian steal syndrome. It is called as subclavian steal syndrome. And then we'll come to grafts. What are the grafts that we are using for artery either bypass or repairing of your arteries? So most importantly, what are the grafts that we use? We use a autograft. We use a allograft or tissue cultured graft. We use a xenograft. Xenograft have very high level of rejection, and autograft is good. And which is the most common preferred vessel for autograft? It is your saphenous vein. Please remember, saphenous vein is the most important autograft that we are using for correction anywhere. For correction anywhere in our body. Allograft is somebody else's, but that is also not. And what is important question? Which layer of vascular structure causes rejection of graft? It is the smooth muscle layer cell. That is the media, tunica media, which will proliferate the smooth muscle cells because of reaction, and ultimately failure of the graft takes place. It is the tunica media or the smooth muscle layer cell. That is what you should remember. So the smooth muscle layer cell, so our autograft, how it gets rejected, that's what I said. Autograft, allograft, xenograft, a tissue culture graft. Then you have artificial grafts, that is Dacron. The most commonly used is Dacron patch. Any answer, when you have an entrance bit, which is the most common what do you call this, man-made graft, or what is that word we use for it? Synthetic graft. This is Dacron graft. And Dacron graft is again of two types. One is woven transversely, one is woven horizontally. Most important, Dacron graft. And Dacron graft, and then there are two synthetic, that is semi-synthetic. Then there are synthetic two, PTTE, P, small p, TTE, capital. That is one graft, and another graft is, I just forgot, yeah. PTTE and probably I'll tell in the next class. I'm not able to remember. So Dacron graft is important. Now the question is, so many graft questions. What is the most important arterial graft in CABGS? Lima, left internal mammary artery. Left internal mammary artery, and the results are excellent. Followed by your saphenous vein. Saphenous vein. What is the most common arterial graft, artificial graft that we use? That is Dacron. What is the graft that you use for abdominal aorta? Saphenous vein or Dacron. But saphenous vein is more important. I think most of the times, yeah. For any bypass graft, what is the most common vein or artery vein used is your saphenous vein. These are the veins that we use. Dacron patch, saphenous vein, Lima, left internal mammary artery for CABGS. I vascular graft, subcutaneous abdominal aorta aneurysm, aortic dissection, diabetic foot, Raynaud's phenomenon, thoracic outlet obstruction, DeBakey's right lateral wall, Raynaud's phenomenon. Yeah, done. Any doubts? Yeah, another thing I wanted to tell was Fogarty's catheter. Whenever there is an aneurysm, actually I should have spoken about embolus. Whenever there is an embolus, if the embolus is not getting treated by your conventional methods of using heparin, low molecular weight heparin or embolectomy, then you go for a Fogarty catheter insertion. It's a Fogarty catheter is a lengthy tube which has got a balloon. So it will go there. First it will pull the thrombus and then do a balloon dilatation. This is called as Fogarty's catheter. Please remember, Fogarty's catheter is number of times has been asked in entrance. Anybody has any doubts? I'm just looking here. Any doubts? So everybody is smart enough that nobody will ask any question, is it? No doubts, is it? Alright, all the best. I'll start venous system in the next class. Yeah. See you. If any doubts, you can still put in the YouTube. YouTube questions. I'll solve it to you there. Is that fine? Oh, thank you, Avinandan. How are you? Hopefully, Bihar is doing well. Fine. You can put it down in the comments box. Need be, I'll answer there. Fine. Take care. See you all.